Dear doctors, welcome to the most important and most happening topic of 2020. What is that? Yes, it is COVID in pregnancy. Okay, so we're going to discuss about SARS-CoV-2 infection in pregnancy, and this is where we expect maximum MCQs from for the 2021 NEET PG, right? Okay, so COVID in pregnancy, and what we're going to see now is the RCOG recommendation on the management of COVID in pregnancy. Okay, so let's get started with it. So first point here is about the mode of transmission. Mode of transmission, as we all know, the mode of transmission is human to human, right? By close contacts or with droplet infection or through fomites. This is the usual mode of transmission. But now we're talking about COVID in pregnancy. So what are we worried about here? We're worried about vertical transmission, right? Okay. So does it exist? Does vertical transmission exist with COVID? As of now, the incidence of vertical transmission is very, very less. Okay. So though vertical transmissions have been reported, the incidence of vertical transmission, okay, the incidence of vertical transmission means mother to baby transmission, right? Okay, the incidence of vertical transmission is very less. Okay, it is very less. It's very uncommon. Okay, but remember, even if there is a vertical transmission, even if the baby is proven to be infected from the mother, either during the antenatal period or in the intrapartum period, this is not going to affect the mode of delivery. This is not going to affect the method of feeding. It is not going to affect the roaming in any way. That means even if there is a vertical transmission and even if both the mother and the baby are infected, they're going to follow the same guidelines on feeding, roaming in, and the mode of delivery, which we will be discussing in the due course. Okay, so as of now, just remember, mode of transmission is usually through fomites or direct contact, human to human contact, or through droplets. But regarding vertical transmission, yes, it is possible, but the incidence is very, very less. Okay, so next, regarding symptoms of COVID in pregnancy. Symptoms of COVID in pregnancy. Okay, the most common symptom in pregnancy is fever. Most common symptom in pregnancy is fever, a possible MCQ, okay. But remember, 70% of infected women are actually asymptomatic, okay. 70% of the infected women are actually asymptomatic, okay. So fever is the most common symptom among those who are symptomatic, okay. So what percentage of women present with fever? Among the women who are symptomatic, 40% of them present with fever, okay. Among the women who are symptomatic, 40% of them present with fever. And the second most common symptom is cough, okay. The second most common symptom is cough. Again, 39% of those who are symptomatic present with cough. Okay, so forget the general symptoms. Now coming to pregnancy, which is the most common symptom of COVID infection in pregnancy, it is fever. Okay, the second most common symptom is cough. Apart from fever and cough, there can be other symptoms like dyspnea, myalgia, loss of smell, loss of taste, okay, diarrhea, dyspnea, myalgia, loss of smell, loss of taste, and diarrhea. And remember, only 10% of the pregnant women present with these symptoms, okay. Dyspnea, myalgia, loss of smell, loss of taste, and diarrhea are seen only in 10% of the pregnant women who are infected, okay. So which is the most common symptom during pregnancy? Fever is the most common symptom during pregnancy, and cough is the second most common symptom during pregnancy. And remember, most of the women are 74% of the women are actually asymptomatic, okay. So now, when it comes to symptoms, the next leading question is whether this pregnant lady is more symptomatic than a non-pregnant lady, whether the symptoms are more pronounced during pregnancy. The answer is actually no, okay. The truth is what? Pregnant women are less symptomatic than a non-pregnant lady, okay. I know you will be surprised to know this data, but yes, this is the fact. Pregnant women are less symptomatic, okay. Pregnant women are less symptomatic than non-pregnant women of the same age, okay. pregnant women are less symptomatic than non-pregnant women of the same age. Okay. So we have 3 trimesters in pregnancy, right? First, second and third trimester. Is there any difference between the symptoms that usually appear in the first trimester and the symptoms that are usually seen in the second trimester? And with regards to trimesters, which trimester is more symptomatic, which trimester is less symptomatic, which trimester is more dangerous? Again, you have to know that. Remember, first and early second trimester. First and early second trimester is when the disease is usually mild. Okay, the disease is not that severe, the disease is usually mild. The severity increases as gestation advances. Okay, severity increases as gestational age advances. Okay, as gestational age advances, the severity increases. Very, very important MCQ point. Okay. So, the median age at gestational age, the median gestational age at hospital admission is 34 weeks. Okay. The median gestational age at hospital admission is, that means even if the woman gets infected in the first and the early second trimester, it does not usually end up in hospital admissions. Rather, they are usually at home isolation because they are usually asymptomatic, or they either present with mild symptoms or they are asymptomatic. Okay, but as gestation advances, they usually present with moderate to severe symptoms, and that is when they will require hospital admission. And the median age, gestational age at hospital admission is 34 weeks. Okay, it's 34 weeks. Okay, so now we will summarize about the symptoms. Okay, so what is the overall severity of a pregnant lady when compared to a non-pregnant lady? See, I told you already, pregnant lady presents with less symptoms when compared to a non-pregnant lady than a non-pregnant lady. Okay, but if a pregnant lady presents with symptoms, remember the severity of the symptom is more if she presents with symptoms in a pregnant lady. And not only this, ICU admissions. Okay, the need for intensive care unit admission is more for a pregnant lady than a non-pregnant lady. Okay. So, where is ICU admission more? Pregnant or non-pregnant? Yes, pregnant. Okay. ICU admissions are more for a pregnant lady than a non-pregnant lady. Okay. So, now I will summarize the symptoms of COVID-19 infection during pregnancy. Okay. So, yeah, vertical transmission, if at all present, is very rare, and usually 74% of the pregnant women are asymptomatic. The most common symptom is fever, and the second most common symptom is cough. Among the symptomatic women, 40% of them present with fever, 39% of them present with cough. Rarely a pregnant lady can present with dyspnea, myalgia, loss of smell and loss of taste and diarrhea, and these account only for 10% of the symptoms. Okay. So, who is more symptomatic, pregnant or a non-pregnant lady? A pregnant lady is less symptomatic than a non-pregnant lady, but if at all symptoms appear, pregnant ladies' symptoms would be more severe than a non-pregnant lady, requiring frequent hospital ICU admissions. Okay. And also remember, as the pregnancy advances, the severity increases. In the first and the early second trimester, that means the first half of the pregnancy, the disease is usually asymptomatic or mild. In the second half of the pregnancy, the disease is usually moderate to severe, and the usual gestational age at hospital admission is 34 weeks. So, next million-dollar question here is the effects of COVID on pregnancy. Okay. Effects of COVID on pregnancy. Okay. So, there is an increase in the rate of preterm birth, there is an increase in the rate of cesarean section, and also there is an increase in the requirement of general anesthesia. These are the 3 important valid MCQ points that you might expect in the coming NEET PG exam. So, what all have increased here? There is an increase in preterm. There is an increase in preterm births. There is an increase in the risk of cesarean section. Okay, risk of cesarean section. Fine. So remember, overall incidence of preterm birth among COVID positive women is 17%. Okay. Overall incidence of preterm birth in COVID positive women is 17%, and the overall requirement of cesarean section for delivery in COVID positive women was 59%. Okay, 17% and 59%. So the 17% is huge when compared to a lady who is COVID free. Okay, so there is a threefold increase in the risk of preterm delivery with COVID, and there is an increase in the rate of cesarean section with COVID as well. Okay, so remember, 47% of these preterm deliveries are iatrogenic. Okay, so iatrogenic means what? 47% of them are iatrogenic. Iatrogenic means what? For some reason, to save the mother or the baby from complications of COVID, labor has been induced, or an elective cesarean section or an emergency cesarean section has been performed for COVID reasons. Okay, to deliver immediately where there was worsening maternal or fetal condition due to COVID. Okay, and remember, 50% of the cesareans that were performed were due to COVID indications, meaning there was a worsening maternal condition, there was a worsening fetal condition, and in order to save the mother or the baby, a cesarean was performed. Okay, so overall 59% of the women were delivered by cesarean section. COVID infected women were delivered by cesarean section, out of which 50% of indication was due to COVID. Okay, yeah. And also there is an increase in the need for general anesthesia whenever the woman was anesthetized. Okay, there was an increase in the need for what? General anesthesia. Okay, usually we prefer giving regional anesthesia, right? So whenever possible for analgesia, we use epidural analgesia, like in case of hypertension or heart disease, and here again we actually prefer epidural analgesia or anesthesia, but only when the maternal condition is deteriorating, when she is hypoxic, she would require general anesthesia. So when compared to a pregnant lady who is COVID negative, a pregnant lady who is COVID positive required more general anesthesias. That's what I'm trying to tell. Okay, so increase in preterm delivery, increase in the risk of cesarean section, and increase in the need for general anesthesia. Okay, so what happened to the incidence of stillbirth or neonatal death or congenital malformations or intrauterine growth retardation? There are 4 important points which you have to remember, apart from the preterm birth, the cesarean section, and the need for general anesthesia that we discussed. Okay, so what happened to the incidence of stillbirth? What happened to the incidence of congenital malformations? Okay, what happened to the incidence of neonatal death? Okay, and finally intrauterine growth retardation, IUGR, intrauterine growth retardation. Please remember, these 4 are complications which are usually seen in viral infections, and that is why it gains these conditions gain importance here. Okay, so stillbirth, congenital malformations, neonatal death, and IUGR are conditions which are usually seen in viral infections like cytomegalovirus or rubella infection or herpes infection. Okay, but here please remember, this infection COVID-19 is not associated with any of these complications. It does not increase the risk of stillbirth. It does not increase the risk of congenital malformation. No congenital malformation has been attributed to COVID infection till now. Okay, so it does not increase. It is not a teratogenic virus. That's what I'm stressing upon. Okay, COVID is not a teratogenic virus. It is not found to be a teratogenic virus yet. Okay, it only causes acute respiratory syndrome. Okay, SARS. It is not found to be teratogenic. It does not increase the incidence of stillbirth. It does not increase the incidence of growth retardation or neonatal death. Okay, but overall, since this pandemic has begun, there has been an increase in the risk of stillbirth. Okay, so there has been an increase in the risk of stillbirth. That is true, but this increase in the risk of stillbirth has not been attributed to COVID. Okay, it has not been attributed to COVID directly. Okay, maybe the stress level of women are high, or for any other reasons the stillbirth rate would have increased, but it is not found to be due to COVID. Okay, so these are not related to COVID, and these are not seen in COVID infection. So what is seen in COVID infection is a threefold increase in preterm birth, increased rates of cesarean section, and the increased need for general anesthesia. Okay, so hope you will understand these points. Fine. So next is the risk factors for admission. Where all should you admit a patient with COVID? Risk factors for getting admitted, okay. So, where all you expect a severe disease, fine. First point is black population, Asian population, black population, Asian. Second is overweight or obese, overweight or obese, that means a BMI of more than 25, okay, a BMI of more than or equal to 25, okay. Next is pre-existing diabetes or chronic hypertension, okay, pre-existing diabetes or chronic hypertension. So, you know, overweight or obesity has always been a problem, right? It has always been a problem in pregnancy, okay, and it continues to be a problem in pregnancy, and it will continue to do so, okay. See, obese woman is at risk for diabetes, she is at risk for preeclampsia, she is at risk for hypertension, she is also at risk for many infections, and she is also at risk for COVID-19, okay. So, obesity is very, very bad. Apart from obesity, black population and Asian population are at risk. Pre-existing diabetes and chronic hypertension are again risk factors. Maternal age more than 35. Maternal age more than or equal to 35, okay, is another risk. And living in areas of increased socio-economic deprivation, okay, living in areas of increased socio-economic deprivation, okay. So, these are the identifiable risk factors for severe COVID infection, okay. So, black Asian population, obesity, pre-existing diabetes or chronic hypertension, maternal age more than 35 and living in areas of increased socio-economic deprivation, okay. So, if these are present, then the likelihood of a severe infection, the pregnant woman is likely to have a severe infection and she is likely to get admissions, okay. And not only this, there is another important point on vitamin D, okay. So, what does it do to pregnant lady? Vitamin D deficiency increases the risk of infection in pregnant lady, okay. Vitamin D deficiency generally it increases the risk of infection in a pregnant lady, and here it is particularly related to this COVID-19 infection. So, women who are deficient with vitamin D have good chances of getting severe illness, okay. So, the severity of the disease increases. Severity of the disease increases with what? With vitamin D deficiency, okay. So, what does the RCOG recommend? Okay. So, the Royal College of Obstetricians and Gynecologists, the RCOG recommends vitamin D supplementation throughout pregnancy to all high risk population women, especially the Asian and black origin population. Okay. I am again repeating, the guideline recommends vitamin D supplementation. Okay. The guideline recommends vitamin D supplementation to all Asian women or black women or any woman at risk for severe illness, okay. So, risk factors for severe illness have already been discussed. So, whoever is at risk for severe illness, especially this Asian or black population, they all have to be supplemented with vitamin D to reduce the severity of the disease or to prevent the disease, okay. And apart from this, the guideline also supports regular exercise, okay. Guideline also supports regular exercise. So, you wonder if exercise can be done during pregnancy, yes or no? Yes, it can be done. Yes, exercise can be done, okay. Preferably upper body exercises can be done, okay. So, strenuous exercise is what is usually withheld during pregnancy. Regular exercises are allowed during pregnancy, okay. So, regular exercise and healthy diet. Regular exercise and healthy diet is what is important to keep your immune system up, okay. So, fine, we will now brush up our knowledge on the effects of COVID on pregnancy, okay. So, I told you there is an increase in the risk of preterm, there is a threefold increased risk of preterm delivery. Okay, there is a threefold increased risk of preterm delivery. There is a 59% chance of the lady undergoing cesarean section, and there is an increased need for general anesthesia. Okay, but this virus is not teratogenic. It does not increase the risk of stillbirth. It does not increase the risk of congenital malformations, IUGR, or neonatal death. Okay, risk factors are Black Asian population, obese overweight population, chronic hypertension, women with diabetes, increased maternal age more than or equal to 35, and women living in low socioeconomic groups. So, what is the role of vitamin D here? Does it help? Yes, it helps. Okay, so this can be a potential MCQ. This can be a potential MCQ. So, does the guidelines recommend vitamin D supplementation? Yes, guideline recommends vitamin D supplementation. Okay, it recommends vitamin D supplementation. Fine, to high risk women, especially Asian Black women. Okay, and it also supports regular exercise and healthy diet. Okay, so this is about the little effects on COVID in pregnancy and the measures to prevent severe illness. So, what next? Next is antenatal care. Antenatal care. So, how to provide antenatal care? Should you restrict antenatal visits or should you follow the routine antenatal guideline? That is the most important question here. Okay, so follow the routine antenatal care. Okay, so if a lady deserves 16 visits, then she should be given all the 16 visits. Okay, there should be no restriction in the visits. Okay, so follow the routine antenatal care. You don't have to restrict the lady from coming to the hospital for whatever reason she comes. Okay, so fine. Now, if at all she is not able to come, okay, if at all she is in isolation or she is exposed to a case and she has not developed symptoms and she is in isolation, what should be done? Yes, here in this case, if she is put in isolation when she is exposed, you can either go for a virtual consultation. Virtual consultation means a teleconference or a video conferencing kind of thing. Okay, video or a teleconferencing. Yes, this can be done. But remember, whenever the lady requires physical examination, whenever the lady requires an investigation which has to be done in the hospital, then she has to definitely report to the hospital. Okay, so follow routine antenatal care. That's the most important point here. Okay, the same number of antenatal visits should be offered to any lady provided she is not in isolation. Okay, fine. So appropriate screening for all high risk diseases like diabetes, hypertension should be done. Okay, appropriate screening for diabetes mellitus should be done. Okay, so the lady should be subjected for a glucose tolerance test or an oral glucose challenge test according to the local policy. Okay, so regarding smoking during pregnancy, smoking should strictly be avoided. Okay, smoking should be strictly avoided. Okay, smoking should be, of course, even if there is no COVID, smoking should be strictly avoided, but then during COVID, it has to be avoided. Okay, yes, fine. And the woman has to be supplemented with, as I already told you, she has to be supplemented with vitamin D and she has to be supplemented with folic acid. And if she is a candidate for iron therapy, yes, she has to be supplemented with iron as well. We usually give iron only in the second and the third trimesters, right? We don't give it in the first trimester. So, whatever she has to take, like vitamin D or folic acid or iron or calcium or whatever, she has to take it. Okay. So, last but not the least, please remember, vaccine for influenza virus. Okay, vaccine for influenza virus can be administered during pregnancy regardless of which trimester she belongs to. Okay, and why particularly flu virus? Because you all know there is a possibility of co-infection with flu virus and COVID virus. Okay, so influenza vaccine. Okay, can it be given? Yes, it can be given. Okay. Yes, it can be given. Okay. During pregnancy, yes, it can be given during pregnancy. Okay. So, can it be given in all 3 trimesters? Yes, it can be given in all 3 trimesters. Okay. So, what is the purpose of giving this influenza? It not only protects against flu influenza infection, but also avoids the co-infection with COVID-19. Okay, so this is about antenatal care. Follow the routine antenatal care. Supplement the lady with vitamin D, calcium, iron and folic acid or whatever she requires. Okay, and if only she is in home isolation, allow her to take this virtual consultation or teleconsultation, or otherwise make the patient come to the hospital and screen her for diabetes, hypertension or whatever appropriately, and if possible vaccinate her with influenza vaccine. Okay. So next is what? For women who have recovered from COVID-19, how are we going to handle them? For women who have recovered from COVID-19. For women who have recovered from COVID-19 during pregnancy. Okay. See, if she's had mild symptoms or moderate symptoms, or if there were no symptoms at all, and if she did not require hospital admission, then you just follow the same guideline. Okay. So that means mild to moderate disease or asymptomatic disease where the lady did not require hospital admission, the lady did not require hospital care, is where you have to follow the routine antenatal care. Okay, here is where you follow the routine antenatal care. Okay, routine antenatal care. So now why am I stressing on this point? Obviously, she would recover in the next 14 days. For a lady who has got mild disease or no disease at all, no symptoms at all, and she's just been on isolation for 14 days, she would have recovered and she is now a candidate for regular antenatal checkup. But for a lady who has had a severe disease, who has had a hospital admission, what you have to do is at least home isolate her for 14 days and do not subject her for any scan or anything for the next 14 days from the point of recovery. Okay. So for serious illness, okay, for serious illness, what you have to do is, yes, avoid antenatal scans, avoid hospital visit or avoid antenatal scans for up to 14 days, from the point of infection or from the point of recovery? From the point of recovery. Okay, 14 days from recovery. Okay, so two very important potential MCQ points I had told you. You're going to follow the routine hospital antenatal care guideline that you usually follow in your place. You're going to allow her to come to the hospital and take all hospital visits. You're going to check her blood pressure, her sugars or everything according to the existing guidelines, and you are not going to withhold any of her medicines for the sake of COVID positivity. Okay, she's going to take her routine calcium, iron, folic acid and vitamin D or whatever she was taking. Okay, and if she's had a mild to moderate infection and if she did not require hospital admission, then you will subject the woman for routine antenatal checkup and antenatal care. You will not restrict any antenatal visits for the sake of COVID-19 positivity. But if the woman has had a severe illness, okay, if she's had a severe illness and if she was hospitalized, then you would restrict and withhold all her usual antenatal visits for at least 14 days from the point of recovery. I'm telling you, not from the point of admission, from the point of recovery. She has to be kept in home isolation for 14 days, not allowing for any antenatal scans for 14 days from the point of recovery. Okay, so this is about antenatal care. What next here? Next is a very, very important catchy MCQ area, and that's nothing but venous thromboembolism prevention in COVID-19 infection. Okay. So you all know pregnancy is a hypercoagulable state. Yes. COVID infection is also a hypercoagulable state. Yes. So when pregnancy and COVID infection combine, obviously there is an exaggerated hypercoagulable state, and the lady is at risk for developing venous thromboembolism or pulmonary edema or whatever, right? Any thrombotic complications. So there has to be a strict guideline on when to give venous thromboembolism and how to give venous thromboembolism prophylaxis for a COVID positive pregnant lady. Yes. So potential MCQ area, I would say, yes, prevention of venous thromboembolism in a pregnant COVID-19 patient. Okay, prevention of venous thromboembolism in a pregnant COVID-19 patient. First point here, if the lady is positive for COVID, please remember, all suspected or confirmed COVID positive patients, okay, all suspected or confirmed COVID positive patients should be offered prophylaxis with low molecular weight heparin. Should be offered prophylaxis with, I am stressing on this point, low molecular weight heparin, okay, should be offered prophylaxis with low molecular weight heparin. Now the next point is here, if supposing she is not been confirmed to be a positive case and she is just exposed to a positive case and she is in self-isolation. She is only exposed, okay, she is in self-isolation and she has not developed any of the symptoms of COVID yet. What should you do? Here the therapy is only hydration, okay. Here the guideline recommends hydration, okay, good hydration to prevent venous thromboembolism, okay. So for all suspected patients or positive patients, you have to start low molecular weight heparin to prevent venous thromboembolism, and if she is only on isolation and she is not a positive case, then you will have to hydrate the patient, okay. So for how long should you give this low molecular weight heparin, okay. Please remember, this low molecular weight heparin has to be given for at least, okay, for at least 7 to 14 days, 7 to 14 days from the point of recovery, okay, after recovery, okay. That means once she is found to be positive, you will start her on low molecular weight heparin, okay. Supposing say today she is found to be positive and today you start her on low molecular weight heparin, say she takes 10 days to recover. So 10 days of the disease period plus another 14 days of disease free period following the recovery is what you will cover with low molecular weight heparin. So totally together a 24-day period, okay. So 7 to 14 days after recovery, okay, is when you have to stop this low molecular weight heparin, okay. In case she is a postpartum lady, okay, in case she is a postpartum lady who is found to be COVID positive, she is just delivered, say she is 1 week postnatal, okay, yes, you have to start her on low molecular weight heparin. Here again you have to start her on low molecular weight heparin, okay, because until 6 weeks it is considered to be puerperal period where the risk of venous thromboembolism is even more higher, okay. The risk of venous thromboembolism is higher than the antenatal period in the postpartum period. So here what you have to do is again put her on low molecular weight heparin and continue this low molecular weight heparin for at least 10 days after recovery, and ideally it should be continued for 6 weeks until the puerperal period is over, okay. So here put the lady on low molecular weight heparin. For how long will you give this low molecular weight heparin? At least for 10 days after recovery, at least for 10 days after recovery, and ideally for 6 weeks, ideally for 6 weeks, that means until the puerperal period is over, okay. So apart from these indications, if the lady requires low molecular weight heparin for any other reason, like say she is a candidate for low molecular weight heparin because she is an APLA positive lady or she is an SLE positive lady and she was already on heparin, or she already has history of venous thromboembolism in the past for which she was put on low molecular weight heparin, then that should be continued, okay, according to the current guidelines on venous thromboembolism prophylaxis, it has to be continued, okay. So fourth point, if she was already on heparin, for any other indication, for other indications, yes, it has to be continued according to the current guidelines, okay. It has to be continued according to whatever the disease guideline is, okay. So this is about prevention of venous thromboembolism, fine. All positive patients suspected or confirmed, yes, give heparin, okay. All patients who are in self-isolation, not found to be positive, just hydrate them. All postpartum patients with COVID positivity, put them on low molecular weight heparin and continue heparin ideally for 6 weeks. And if the patient was already on low molecular weight heparin for any other indication, then just continue to have the woman on low molecular weight heparin until she delivers and stop it whenever it has to be stopped according to that particular disease guideline, okay. So this is about prevention of venous thromboembolism in pregnancy. So next we will discuss about the labor and birth, okay. So how are we going to manage labor, okay. So, if she is a COVID positive asymptomatic patient, okay, if she is a COVID positive asymptomatic patient, there are 2 points that you have to remember. What are they? First point is that these women need not be monitored with continuous electronic fetal monitoring, okay, and these women need not require continuous CTG monitoring. These women do not require any special delivery suit, okay. So, these women do not require continuous electronic fetal monitoring. Continuous electronic fetal monitoring means CTG, okay. They do not require continuous CTG monitoring. So, continuous CTG monitoring is only for high risk patients, right, not for all patients. Here we consider them a non-high risk patient and we don't offer them a continuous CTG monitoring. Second thing is what? No special delivery unit required here, okay. No special delivery unit required, okay. If they are asymptomatic COVID positive patients, okay, they are asymptomatic COVID positive and they've been tested positive for COVID in the last 10 days prior to birth, okay. So, they've been tested positive for COVID in the last 10 days prior to getting admitted for delivery, okay. But if the patient is symptomatic, okay, how are we going to handle symptomatic COVID positive women in labor, okay. For all women who are symptomatic, please remember they are supposed to remain at home in the latent phase, okay. They are supposed to remain at home in the latent phase and they are supposed to report only in the active phase, okay. Get admitted only in the active phase of labor, okay. Next is this. These women should be monitored with continuous electronic fetal monitoring, okay. They should be offered continuous CTG monitoring and not only this, remember they should be monitored with hourly vitals, okay. Pulse, blood pressure, all these should be monitored hourly and they will have to be delivered only at well-equipped obstetric units, okay. They'll have to be delivered at well-equipped obstetric units, okay. That means a tertiary care unit, okay. So, they'll remain at home until the latent phase is over and they'll get admitted only in the active phase and they have to be offered continuous electronic fetal monitoring, hourly vitals and deliver only in a tertiary care hospital, a well-equipped hospital obstetric unit and aim to keep the oxygen saturation more than 94%. You have to escalate the oxygen supply accordingly, okay. And also remember 2 important points on labor management. COVID-19 is not an indication for cesarean section until the lady is able to manage labor. As long as a lady is able to manage labor, COVID-19 is not an indication for cesarean section. If only the patient develops gross dyspnea and she is not able to cooperate for labor, it becomes an indication and that desaturation becomes an indication for general anesthesia and cesarean section, okay. So, fine. The final point is what? Fetal blood sampling or fetal scalp electrode, okay. Fetal blood sampling or fetal scalp electrode, okay. So, where do we do this fetal blood sampling? Fetal blood sampling is done whenever the CTG is abnormal, right, okay. Whenever the CTG traces are suspicious, whenever the CTG trace shows atypical variable deceleration, to see whether the fetus is hypoxic or acidotic, we do a fetal blood sampling and then decide on whether to do a cesarean section or not, okay. So, fetal blood sampling for a COVID positive pregnant lady, can it be done? Answer is yes, okay. Yes, COVID positivity is not a contraindication for fetal blood sampling, okay. COVID positivity is not a contraindication for fetal scalp electrode, okay. Fine. Next important point is on the timing and the mode of birth, okay. As I already told you, COVID positivity is not an indication for cesarean section. COVID positivity is not an indication for cesarean section and the mode of delivery will entirely depend on the obstetric scenario. Okay, if she is a candidate for vaginal delivery according to other obstetric scenario, then she should be delivered vaginally, or if she is a candidate for cesarean section and if she has contraindications for vaginal delivery, then she will be delivered by cesarean section. Okay, so the mode will depend on the obstetric indication. Okay, obstetric indication and not COVID status. Okay, but if the woman is severely compromised and if she is desaturating, okay, if she is severely compromised and she is desaturating even with oxygen, in that case she might not cooperate for a vaginal delivery, and in that case, to save the mother and to hasten the process of delivery, you will be forced to do a cesarean section. Okay, so this is about the mode of delivery, and the timing of birth is not influenced by COVID status as long as the mother's vitals are stable, as long as the mother's saturation is stable. So, if only you are forced to deliver the baby because the lady is desaturating even with oxygen, then the timing of delivery is influenced by COVID status, or otherwise the timing of delivery is not generally influenced by COVID status. Okay. Next is about birth attendant, birth partner. Okay. So, can we allow birth partners for a COVID positive patient? Yes, we can. Okay, even if she is not COVID positive, for any other pregnant lady in this pandemic situation, yes, birth partners can be allowed with certain precautions. Okay, so what precautions would you follow before you allow a birth partner inside the labor room? You ask for history of fever or cough or loss of smell or taste in the preceding 10 days. Okay, so fever, cough or smell, loss of smell or taste in the preceding 10 days, and if these are present, then you will not allow that particular person as a birth attendant. Okay, so if there is severe fever in the last 48 hours, again you will not allow this patient as a birth attendant. So if these are present, okay, you will not allow this person as a birth attendant. If only there is no history of fever or cough or loss of smell or taste or any other symptoms suggestive of COVID-19, and the attendant or the person is willing to wear a mask and willing to abide by the rules of the hospital, then she will be allowed as a birth partner or a birth attendant. Okay. So, regarding water birth. Water birth. Can we allow water birth? Water birth is famous nowadays, isn't it? So, most of the celebrities are opting for water birth because they say water birth is painless, water birth is relatively easy. So, can we allow water birth for a patient who is COVID positive? So, please remember, asymptomatic COVID positive women can be allowed for water birth. Okay, can be allowed to undergo water birth. Symptomatic COVID positive patients should not be encouraged for water birth. Okay. So, asymptomatic COVID positive women can be allowed to undergo water birth. Symptomatic, if she has fever, obviously she cannot be comfortable inside the water, right? So, symptomatic COVID positive women should be denied water birth services. Okay. So, finally, labor analgesia. Okay. So, which analgesia do we prefer? Entonox is safe. Entonox can be given. Entonox can be given. Entonox is safe, okay, but you have to give it with a single use microbiological filter, okay, single use microbiological filter. So, Entonox can be used, but if at all you need anesthesia, then the preferable mode of anesthesia is epidural, okay. If the woman requires anesthesia, then epidural would be ideal, not general anesthesia, because general anesthesia increases the risk of aerosol formation and infection, right? But in certain cases where the woman is desaturating, general anesthesia, you would be forced to give a general anesthesia, but otherwise epidural anesthesia would do. Okay. So, next point is here, where all to test for COVID-19. Yes, here we have some indications for testing for COVID-19. Okay. So, this is it. Loss of taste, loss of smell, any symptom that is related to COVID like loss of taste, loss of smell, clinical or radiological evidence of pneumonia, ARDS, acute respiratory distress syndrome, fever more than 37.8 degrees Celsius plus any one of the following, okay, any one of the following: acute persistent cough, hoarseness of voice, nasal discharge, nasal congestion, shortness of breath, sore throat, wheezing or sneezing, okay. So, these together make the criteria to subject the woman for COVID testing. Okay, so where all to test for COVID-19: loss of taste, loss of smell, clinical or radiological evidence of pneumonia, ARDS or fever more than 37.8 degrees Celsius with sore throat, with cough, with hoarseness, with nasal discharge or nasal congestion or wheezing or sneezing or shortness of breath. Okay, if these are present, then you have to subject the woman for COVID-19 testing. Fine. So, if required to diagnose COVID-19, can you subject a pregnant lady to CT or X-ray chest? It is a very, very important question because CT scan is the primary tool to diagnose COVID-19 lung damage during pregnancy, and now because CT exposure is not safe during pregnancy, this has become a viral question on whether to subject the pregnant lady for CT chest during pregnancy. Okay, and the guideline says because the priority is given to the mother's health, the guideline says yes, we can subject the pregnant lady to CT or chest X-ray whenever required. Okay, a very, very important MCQ point. Okay, very important MCQ point. Can X-ray be done in suspected cases? Can CT chest be done in suspected cases? The answer is a big yes. Okay, yes, CT chest can be done in suspected cases of COVID-19 during pregnancy. Okay. So, we will move on to the management of COVID-19 in pregnancy, what all to give, what all not to give, and how to care in the postpartum period. So, management of clinically deteriorating cases. Okay, what all should we do? We have to monitor her vitals. We have to make a early recording of respiratory rate, oxygen, saturation, IO chart, and all these. Okay, so early monitoring of respiratory rate, IO chart and oxygen saturation. Okay, so what are the warning signs that will alert you or escalate the critical care? Okay, so the warning signs are increase in oxygen requirement, okay, to above 40%, increase in respiratory rate to more than 30 beats per minute, 30 breaths per minute, more than 30 breaths per minute. Okay, regardless of or despite oxygen therapy, okay, decreased urine output or acute kidney injury, drowsiness despite oxygen therapy, okay, drowsiness despite oxygen therapy, okay. These are the important alert signs. Okay, these are the important points that will alert you, the findings that will tell you that the woman is worsening. Okay, increased oxygen requirement above 40%, increased respiratory rate more than 30 breaths per minute despite oxygen therapy, drowsiness despite oxygen therapy, and decreased urine output and acute kidney injury. Okay. So, now we will see certain valid MCQ points on the management of COVID in pregnancy. We have certain important MCQs. Okay, the first MCQ is here. How are we going to manage hypovolemia? Okay, so how should you give fluid? Remember, whenever there is hypovolemia, 250 to 500 ml of bolus fluid should be given and not beyond this. Okay. So, you first give only a bolus of 250 to 500 ml and then reassess the patient and decide on further IV fluid transfusions. Okay. Next is on low molecular weight. We have already discussed. I told you all pregnant COVID-19 patients should be put on low molecular weight heparin. Okay. All pregnant COVID-19 patients should be started on low molecular weight heparin, and this heparin should be continued for at least 7 to 14 days from the point of recovery. Okay. Next is, you will also, along with low molecular weight heparin, you will also put the patient on aspirin. Okay, you will also put the patient on aspirin. Okay, but the hazard is what? With aspirin, sometimes the patients would develop thrombocytopenia, right? Okay, in that case, you will be forced to stop aspirin. So, when will you stop aspirin? If the platelet count is less than 50,000. If the platelet count is less than 50,000, stop aspirin. Okay. If platelet count is less than 50,000, stop aspirin. And to replace the effect of aspirin as an adjuvant, you can use mechanical cuff compressors. Okay. So, what you can use is mechanical cuff compressors. Okay, you can use mechanical calf compressors to prevent deep vein thrombosis. Okay, next is on steroids, antenatal steroids. Okay, so yes, the disease process itself responds to steroids, and the guideline recommends two important steroids here. Either you give oral prednisolone, okay, either you give oral prednisolone 40 milligram once daily, or you give hydrocortisone, IV hydrocortisone 80 milligram twice daily. For how many days? For 10 days. Okay, for 10 days from discharge or until discharge, from diagnosis or until discharge. Okay, this is not from recovery like how we saw for heparin. This is from diagnosis or until discharge. Okay, so oral prednisolone 40 milligram once daily, or IV hydrocortisone 80 milligram twice daily. Okay, so this is steroid for the mother to decrease the disease progression. I am not talking about the steroid for the baby to hasten the lung maturation. Okay, so this is steroid for the mother. Okay, so next is antiviral drugs. Can the routine antivirals that we give for COVID-19, can we give those antivirals during pregnancy? Answer is yes. Antiviral, whatever antiviral drug we follow for a non-pregnant lady, the same antiviral drug can be given during pregnancy as well. Okay, so antenatal steroids for lung maturation, we give steroids to the mother to hasten the baby's lung maturation, and what we usually give is either dexamethasone or betamethasone. Can we give these steroids during pregnancy to hasten the lung maturation for the baby? Again, the answer is yes, we can. Okay, so steroids can be given, magnesium sulfate can be given. Magnesium sulfate is usually given for neuroprotection, right? So magnesium sulfate and steroids can be administered to the mother during COVID infection to hasten the lung maturity or for neuroprotection purposes. Okay, so they can be given. So this is about the management guidelines on COVID-19 in pregnancy. So quickly I am summarizing. Yes, so hypovolemia, how to treat hypovolemia? 250 to 500 ml of bolus IV fluid should be given. Low molecular weight heparin should be given. All COVID positive patients during pregnancy and should be continued for at least 7 to 14 days after recovery. So plus or minus aspirin you will usually give, but if the platelet count drops to 50,000, you will stop aspirin and you will replace it with calf compressors. Steroids for the mother, the choices are prednisolone or hydrocortisone. Steroids to hasten the lung maturity, yes, the choice is usual dexamethasone or betamethasone and can be given. Antivirals can be given. Magnesium sulfate for neuroprotection, yes, can be given. Okay, so last few points on postpartum care. So last few points on postpartum care. Okay, so first question here, the most important question here is, can we allow a COVID-19 positive mother to be with a baby? Can we allow rooming in? Answer is yes. The mother and the baby should not be separated at any cost, even if the mother is found to be COVID positive. Rooming in should be allowed regardless of whether the mother is COVID-19 positive or negative. Okay. Skin to skin care. So we call it kangaroo mother care, right? Skin to skin care should be encouraged. Skin to skin care or that kangaroo mother care should be encouraged. Okay. Next is what? Breastfeeding. Breastfeeding. Should breastfeeding be allowed? Answer is a double yes. Breastfeeding should be allowed regardless of whether the mother is a COVID positive mother or a COVID negative mother, whether she is a symptomatic mother or an asymptomatic mother. These parameters do not matter at all. Okay. May happen what? Breastfeeding should be encouraged regardless of the COVID status. Okay, breastfeeding should be encouraged, skin to skin care should be encouraged, rooming in should be allowed. Okay, in case the mother is severely ill, okay, in case the mother is severely ill, in case the mother is not able to feed the baby because she is severely breathless or her SATs are very low, you have to express the breast milk, okay, using a breast pump, okay, preferably a breast pump. Okay, in case the mother is severely ill, just express the breast milk with a breast pump. Okay, next question is on the Mask for babies, okay? Mask. Should babies be protected with face mask? Answer is no. Babies should not be allowed to wear face mask. Babies should not be, encouraged. Face mask should not be encouraged for the neonate, okay? Because it might produce suffocation and we might not know when the baby will end up in suffocation, okay? So, yeah. Neonates should not be encouraged to wear. Neonates should not be, allowed to wear face masks. They should not be treated with face masks at all, okay? So, fine. For COVID positive women who have recovered from the disease, ask them to self-isolate at home and follow the usual postnatal care. Apart from these points, please remember other postnatal care is the same as for a COVID negative lady. So, postnatal care is the same as a COVID negative lady. So, this is about postnatal care. Rooming in allowed, skin to skin contact allowed, breastfeeding, yes, mandatory. If she is severely ill, express the breast milk and feed the baby with this expressed breast milk. Neonates should not be given face masks and yes, postnatal care is otherwise the same. Fine. Following our discussion of COVID-19 infection in pregnancy, we have few MCQs here to discuss, and these are questions which probably can be expected in the coming NEET PG exam. Okay. So, here's question number 1. Which of the following statement is false about COVID-19 infection in pregnancy? Option A, vertical transmission is uncommon. Yeah, vertical transmission is actually uncommon and this is a true statement. Vaginal delivery increases the risk of vertical transmission. No, this is a false statement. Mode of delivery has got nothing to do with the rate of infection. Okay, mode of delivery actually does not influence the rate of infection. Okay, vertical transmission is not affected by method of feeding. That's again true. Okay, vertical transmission is not affected by method of feeding. So, breastfeeding and rooming in should be encouraged regardless of COVID status. Okay, regardless of the COVID status, breastfeeding should be encouraged, and vertical transmission is not found to cause congenital malformations. That's again a true statement. Okay, COVID virus is not found to be teratogenic. No cases of congenital malformations have been reported after COVID-19 infection. Okay, so the false statement here is option B. So, next question here. Which of the following statement is true about COVID-19 infection in pregnancy? Pregnant women contract the infection more frequently than the general population. No, this is a false statement. The rate of infection is not increased with pregnancy. It is only the severity of the illness that is increased. Okay, the rate of infection is the same. Fine. Pregnant women are found to be more symptomatic than non-pregnant women of the same age group. That is again false. Okay. Pregnant women are found to be less symptomatic. If at all they develop symptoms, the severity of the symptoms would be more. Okay. Pregnant women are almost always symptomatic when infected. This is again false. Okay. Most of the pregnant women are asymptomatic. 74% of the infected pregnant women are actually asymptomatic. Okay. Only a very few of them are symptomatic. Okay. Severity is more for pregnant than non-pregnant women of the same age group. This is a true statement. Okay. Severity of the infection, severity of the symptoms increase with gestational age. Okay. So, yeah, this is a true statement. So, next question here, question number 3. Most common symptom of COVID-19 in pregnancy is fever. Most common symptom of COVID-19 in pregnancy is fever. Okay. Question number 4 here. COVID-19 infection in pregnancy is most severe in the 3rd trimester. It's most severe in the 3rd trimester. In the discussion, I have mentioned this point very clearly. The average gestational age at which the woman gets admitted is 34 weeks. Okay, the average gestational age at which the woman gets admitted is 34 weeks. Okay, the hospital admission, ICU admission increases with pregnancy because the severity of the illness increases with pregnancy. Okay, so the most vulnerable period is the 3rd trimester. Question number 5. Risk of which of the following is increased with COVID-19 infection in pregnancy? Okay, I told you in the discussion there is no increase in stillbirth, there is no increase in congenital malformations, there is no increase in the incidence of IUGR. The increase in stillbirth is not actually, there is an overall increase in stillbirth, but it is not attributed to COVID infection. Okay, but what is actually increased due to COVID? Preterm births. Very important question. The incidence of preterm birth has increased after this COVID pandemic has begun, okay. Along with an increase in the incidence of preterm birth, there is an increased incidence of cesarean section. The need for cesarean has increased, and also the need for general anesthesia has increased with COVID infection. Next question here, question number 6. Identify the false statement regarding anticoagulation and COVID-19 infection during pregnancy. Okay. So yeah, pregnancy itself is a prothrombotic state. Adding to it, COVID infection again is a prothrombotic state. So definitely the woman is at risk for developing pulmonary edema or deep vein thrombosis. So we'll see how to give thromboprophylaxis. Low molecular weight heparin, if indicated for other causes, should be continued. Absolutely true. If she requires low molecular weight heparin for any other cause, then this should be continued according to the routine guideline. Okay. All pregnant women with confirmed or suspected COVID-19 infection should be offered prophylactic low molecular weight heparin unless birth is expected within 12 hours. This is again a true statement. Okay. All pregnant women suspected to have COVID infection or confirmed to have COVID infection should be treated with low molecular weight heparin. Okay. All women with COVID-19 infection in the postpartum period should be treated with low molecular weight heparin, preferably until 6 weeks postpartum. Again, this is a true statement. Okay. At least it has to be 10 days from the point of recovery. Ideally, it has to be for 6 weeks postpartum. Okay. Thromboprophylaxis once commenced should be continued for 7 to 10 days from diagnosis. This is a wrong statement. Okay. Why? It has to be continued for 7 to 10 days from recovery. Okay. From recovery. So, once you started, you give it as long as symptoms persist, and once the candidate has been tested negative for COVID, continue for 7 to 14 days from that point. Okay. So, 7 to 14 days from recovery is when you have to stop. Question number 7. Identify the false statement about COVID-19 infection in pregnancy. Continuous electronic fetal monitoring is not required for asymptomatic COVID positive women in labor. This is a true statement. Continuous electronic fetal monitoring, that means continuous cardiotocography, okay, it's required only for symptomatic women, not for asymptomatic women, okay. COVID-19 infection in pregnancy is not an indication for cesarean delivery. Yes, it's not an indication for cesarean delivery. As long as the mother is stable and she is able to cooperate for vaginal delivery is the ideal mode of delivery, provided there are no other indications for cesarean section. If at all you do a cesarean section, it would only be for obstetric indications, not for COVID indications, as long as the patient is stable. If the patient requires life support and she is not able to cooperate for vaginal delivery, then that would become an indication for cesarean section, not COVID infection as such. Fetal blood sampling is better avoided in infected women. This is a false statement. Okay, this is a false statement. Fetal blood sampling can be done. Okay, forceps delivery can be done, ventouse delivery can be done, instrumental delivery can be done, labor can be induced, labor can be augmented. Okay, there are no contraindications for induction of labor, augmentation of labor, fetal blood sampling, instrumental delivery, as long as the patient is stable. Okay, so COVID-19 infection is not a contraindication for routine obstetric practices. Entonox is safe for labor analgesia. Yes, again, this is true. If used with single use filters, Entonox is actually safe, but the preferred mode of analgesia is epidural. Okay, epidural, but yeah, Entonox is not contraindicated. Deficiency of the following vitamin increases the severity of COVID illness during pregnancy. What is it? Yes, you're correct. It's vitamin D. It's vitamin D. And that is why the RCOG guideline recommends vitamin D supplementation for women who are susceptible for vitamin D deficiency, like low socioeconomic women and certain ethnic backgrounds like black women. So, guideline supports vitamin D supplementation for these women. Question number 9 here. Identify the false statement about management of COVID-19 infection in pregnancy. Option A. Oxygen saturation is ideally maintained to more than 94%. Okay, more than 94%. This is a correct statement. Stop aspirin if platelet count falls below 50,000 per cubic mm. This is again a correct statement. Antenatal steroids for fetal lung maturation can be given according to the routine guidelines. Yes, COVID infection is not a contraindication for antenatal steroids. Neither it's a contraindication nor there is any change in the recommendation, routine recommendation. Okay, so it can be given as per the available guidelines. Antiviral therapy is better avoided for their teratogenic effects during pregnancy. No. Okay, antiviral therapy can be given for COVID-19 positive pregnant women. Okay, pregnancy is not a contraindication for antiviral therapy during COVID infection. Okay, So this is the false statement. What's your advice on breastfeeding in COVID-infected women? Breastfeeding is better avoided in all COVID-infected women until recovery. No. Breastfeeding should be encouraged only in asymptomatic COVID-positive women and not in symptomatic. Again, no. Express breast milk would not be ideal as virus is shed in breast milk. No, no. No cases have been reported till now where the infection was spread by breast milk. No. Okay. Breastfeeding and rooming in should be encouraged regardless of the COVID status. This is perfectly right. This is perfectly right. Okay. Breastfeeding and rooming in should be encouraged regardless of the COVID status.